All clear to get started.
Okay, well, good evening, everyone. This webinar will be about a new resource that will be available on ACAP's website. This resource is called the Clinical Reasoning Toolshed. We hope this will be a source of information that can be used by different types of physical therapy educators and researchers who have an interest in using clinical reasoning. This presentation will be provided by the Clinical Reasoning Educational Work Group. My name is Kevin Helgeson. I'm joined by Anita Campbell, Jackie Ruin, and Matt Walk. Our group was originally formed as part of the Clinical Reasoning Consortium, and we've continued to work past that time because we found a project that we really like and want to continue to work on to use clinical reasoning and make it more available for use by physical therapy educators. You may recognize our previous work. We have a couple of YouTube videos out there on critical thinking versus clinical reasoning and the thinking fast and thinking slow, type 1 and type 2 thinking that we hope that you might be using with and sharing with your students. And so our group has continued to work on a tool shed, and we want to present that information this evening. So the plan is to briefly summarize clinical reasoning tools that are available in healthcare education and provide some examples. And then we want to talk about the process that we've used to put together this central repository and keep it organized and make it hopefully useful for your use in your educational settings. And then talk about how we leverage our clinical reasoning community to help us out with this process. And we will eventually invite you to join that process as well. Then we'll be on to using the clinical reasoning toolshed. Matt will take you through the toolshed, show you how it operates, and give you some examples of some potential uses by educators in physical therapy. And from there, we hope you'll dive into the toolshed and see what's currently available with this new resource.
Okay, so and if we're kind of coming and going in our visibility, that's just us taking a time out on our videos. So we would like to know who's here, and we also have a pretty large group, and so rather than have everybody kind of use the functions of Zoom, we would like you to maybe think of doing a quick QR code scan just to give us a little insight. What we're interested in knowing about you all is in what setting are you primarily doing some teaching? Is that in a clinical setting? Is that in a didactic setting? And are you currently using some sort of formal assessment tool for clinical reasoning, particularly something that's been described in the literature? And so if you all are filling that out, and I see responses coming in, so we're rolling here. Let us get up to at least a good 50% of the participants or so responding before I report out on what we've got here. I know sometimes scanning the QR code on a screen is a little tricky. Okay, we're getting there. It looks like consistently so far what we're seeing is consistent with what we've seen when we've spoken with other audiences as well. So about 85% of this group is primarily in the didactic setting as opposed to the clinical setting. And I know I saw quite a few people around here who are SCCEs or DCEs in this call. I'm a DCE as well. And so I kind of have a foot in both of those realms when it comes to my teaching. And then when asked about using a formal tool that exists out there, we are currently at about a third that say yes and 2/3 that say no. So terrific. We're glad you're here in either direction, and we're excited to see what we can do to help enhance that for you this evening. So we'll go ahead and jump into our next section. My role is to sort of lay the groundwork here for everybody. And so I'm going to start with this model, and hopefully this is a familiar model for many of you, but if it's not, I'm going to kind of talk through this a bit. So this came out of Hune et al.'s work in 2019, where they did a conceptual understanding of what is clinical reasoning. And the literature will tell us that there's not a great consensus on what clinical reasoning is, especially across different professions. So this group did a pretty comprehensive exploration of what is it within physical therapy. And so I'm going to read the definition as you sort of look at the model here and find the components that are working together. But clinical reasoning in physical therapy is conceptualized as integrating cognitive, psychomotor, and affective skills. So those are all integrated together. It is contextual in nature, and it involves both the therapist and the client perspectives. It's adaptive, it's iterative, and it's collaborative. The intended outcome is a biopsychosocial approach to patient or client management. So this is really wonderful work that helps us understand what clinical reasoning is and how we conceptualize this within physical therapy. The next question would be, how do we facilitate our learners to be good at all of those components? Whether it's an entry-level DPT student or it is an advanced manual fellow. How are we ensuring that all of those components are happening in the way that they can and should? Well, we need ways to assess that. And so we need an assessment tool. And if we are finding there's gaps in how our learners are doing this, then we also need ways to facilitate their ability to build those skills and to improve upon them. So some additional work that's been done in clinical reasoning is identifying that clinical reasoning is a core competency of what we do as clinicians, and yet we're not necessarily really good at assessing it. In fact, we just figured out how to define it in the last 5 or 6 years, right? So highlighting our friends out of Creighton have done a lot of work in this area, highlighting that clinical reasoning is a missing core competency, regardless of if you are doing competency-based education work. In general, everybody has competencies that they need to meet to function effectively and at the level that they're succeeding to. Additionally, there's this limitation in knowledge translation. So the work that has been done in physical therapy, clinical reasoning, for the profession of physical therapy has not necessarily translated into use. And so we need to use those evidence-based teaching and learning methods and get those out there for everybody to be utilizing together. On this slide, we're just highlighting, here are some of the tools that we're talking about, like what we mean when we say a clinical reasoning tool. So perhaps you're familiar with one of these or several of these. The clinical reasoning assessment tool, or the CRAT, is a common one. Diagnostic thinking inventory, you can read them there, but there's quite a few of these that are available, and we'll talk about them a little bit more as we work through our examples this evening. I'd like to shift just a moment and tap into everybody's clinical mind. And some of you are in the clinic living and breathing this all the time, and some of you maybe haven't been in the clinic in a while, and that's okay. But as clinicians, when we're looking for a way to assess our patient and ensure that they are meeting their goals and moving forward effectively, we might turn to a common repository like the Shirley Ryan Ability Lab to look for some rehabilitation measures in their database. We might go to the EDGE outcome measures. There's a lot of tools out there that can help us decide that our patient is moving forward effectively. And those are really wonderful because not very many practicing clinicians have time and resources to go do a full systematic review of the literature and come away knowing what they need to do. These quick summaries that are vetted and evidence-based are really helpful in keeping us efficient and translating that knowledge into practice quickly. So where do PT educators go when they're looking for evidence-based work in assessing clinical reasoning? or facilitating clinical reasoning. And again, Hune and that research group, which included another paper by Christensen, they went and asked a whole lot of therapists across the country, what do you do when you need to assess clinical reasoning? And the answer was, we make it up. Everybody's recreating something on their own, and we're just making stuff up everywhere and saying, well, that seems like that would assess clinical reasoning. And that's maybe not our best direction to go. We have evidence out there. So our group, we sort of adopted that idea that, hey, if we had something like a Shirley Ryan Ability Lab to go to, wouldn't that be really great? Wouldn't that help us grow as a profession in that we would have a richer, stronger sense of clinical reasoning? And so we have spent the last 3 years now working on building this clinical reasoning toolshed. And Matt, I know if you hit that advance, you'll get the rest of the slide. There we are. Thanks. So our clinical reasoning toolshed, it's this repository where you can rapidly and efficiently find the summaries of the tools that are out there and be able to put those into practice. The goal is to enhance the skill development across a variety of learners in a variety of settings. And if you think back to that model from Hune, there's lots of components of clinical reasoning that need to be addressed as well. And so these are opportunities for us to identify what tools help us to address all of these needs. And when it comes to tools, you always need the right tool for the job, right? It's hard to eat soup with a fork. It's hard to pound in a screw with a wrench, because why would we pound in a screw at all? Right? So some imagery there that just kind of reminds you that it's really important that we have the right tool for the job. So benefits of having a centralized repository. First of all, choices. You have a lot of choices out there. You got to figure out which choice is most appropriate. And so you want something that's searchable that you can access. If you need a tool that helps your learners develop collaborative reasoning and therapeutic alliance skills, that tool is going to look very different than a tool that you're using to assess learners on their diagnostic hypothesis generation for a musculoskeletal condition. Those are two very different needs, right? We want these tools to be evidence-based, as mentioned previously, right? So what we're doing is capturing a summary of peer-reviewed content that's already been published out there. We're capturing that and we're putting it forward in a really efficient way so you can quickly look at this tool and say, is that the right tool for me? Is that what I need for what I'm looking for? We aim to make it efficient and easy to use. So we want repositories to make life easier for everybody, for clinicians and for everybody who's putting that to use, so educators in our case. And with that, it's not just, is it easy to access and get to, but also can you understand it? So that was actually a big part for us, is adapting a consistent shared language that made sense, and we could kind of come to a consensus on what those terms mean so that we could then present tools in a way that was more using that shared language. And that helps to build our community and our ability to study and to utilize these things and to speak the same language. We felt it was really important that this is an accessible tool. And so repositories, they have to be able to reach the people who are going to use them. We have partnered with ACAPT. We were born out of an ACAPT consortium, and ACAPT has continued to work with us on this and is excited to support us despite the fact that we're no longer part of that consortium. We're now building a community of practice around clinical reasoning. And so with ACAPT, it is definitely, its membership is going to be limited to academic institutions who are teaching physical therapy. However, as many of you who are on this call realize, you have the option for individual membership as long as you're affiliated with some sort of institution. A lot of you are clinicians and you're affiliated because you see patients or see students within a system. And so that clears you to be a part of this. And so we're getting ourselves out there to try and reach a high percentage of people who are in the role of instructing clinical reasoning, both in clinical and didactic settings. And then the last piece is driving innovation. So this is a growing area of study as we work to understand clinical reasoning. And as we do this, and as this platform develops, we will identify gaps in the literature. We'll talk a little bit about that today as we go through some things. And that will help us to identify, well, what work needs to be done? hey, there's a gap here. That's already established. Let's direct our energy towards that gap. So I think that that can be really beneficial. That also drives some of that, hey, we need something here, not just because the literature tells us to, but because we as a crowd-sourced group can work together to say, this is a need, let's invest in this as a community. So the last thing that I want to talk about for our time here this evening is how we built this, and because it's important for you to understand how this is created and how this will be maintained as a user and a consumer of this, and hopefully maybe even as a contributor of this. So it is a living resource. We intend to keep this going and updating along the way. When we first developed this, we as a work group, we worked on finding that shared language that I mentioned. So we debated and chipped away and whittled things down and worked really hard on that. And once we felt like we had a relatively solid sense of the language, we then took that back to, at the time, the consortium and the members and said, hey, does this make sense? Is this on track? Does this sound like a project we should continue to invest in? And the answer was a resounding yes. We need this. This would be valuable. Please continue the work. So we kept going. We moved on to phase two. Phase two is collective appraisal. And so in this way, we shared what we were doing with our clinical reasoning community. We started recruiting volunteers. Some of you are here tonight that have been recruited previously, and I know some of you have newly signed up already, even before coming to this presentation, to be volunteers for the next round. So thank you. We asked volunteers to identify whether they were, to self-identify if they felt like they were novice or expert, and then we worked to create small groups that sort of balanced that. So that way experts could help develop novices and move that forward while they were working on this progress of this process, excuse me. So this was met pretty enthusiastically by people who were excited and interested in this clinical reasoning work. They were interested to get involved, but maybe they felt a little unsure about their abilities. They were like, well, I'm not a scholar who's studying this. That's okay. We don't need that. We need people who are going to use it to talk about it. So they were unsure of their qualifications. Additionally, we really tried to make these small, short-term commitments. So essentially, we're looking for about a total of 8 hours out of that small group of 3 in order to put this together. And that can stretch or contract a little bit based on how much literature there is. People are getting this accomplished in somewhere between 1 and 3 months, but we're flexible in terms of that. So it allows a lot of opportunity to dip your toe in the water and participate and then step back out, and it's not a huge commitment, and you're welcome to recommit as often as you would like. So phase 3, we're in this space right now, dissemination. We've launched the toolshed. It exists out there. It is ready to be applied in clinical and didactic settings to a wide variety of learners, and we are getting that word out. So we will spend time tonight talking through how do you use this? How do you think about these pieces? And we'll be pretty transparent. Right now, there's not a lot in the toolshed, partially because there's not a lot of tools that have been published, and because we're working together to crowdsource this and move it forward. And so volunteers like all of you will help us to continue moving forward the ones that we have on deck and waiting to be reviewed. The final piece is the collective upkeep. And so with that, we know that new tools will be coming forward. We know that literature will be updated on the tools that currently exist. And we've adopted sort of like a CPG model where the thought is after we've published it for the first time, within 5 years, we'll come back and we'll research the literature, see what's changed since then. We would plan to start with the same group that had previously worked on that, but then they could potentially opt out, and then we would fill in with additional volunteers. So this allows us to keep everything relevant and up to date to the best of our ability. We focus primarily on those tools that are specific to PT. And then as we get stronger and longer in this, we'll start to spread out, and you'll see a little bit more of that as well. So with that, you now have the whole foundation of clinical reasoning, why we need to work on it. Here's the repository. This is how it's built. I'm going to turn it over to Anita, who's going to talk with you all about what you can expect to find in there.
Yeah, so I will also drop this link in the chat. This is the link to the actual toolshed where you can begin to explore as we're talking about it, or go back to it at a later time. But we wanted to really kind of explain what is on the template and what was used to kind of be able to differentiate between tools so that you can figure out which tool is going to be the best fit for what you're trying to capture with your learners, with your activity that you might be doing, whether that be in the clinic or structured activity in the didactic setting. You can pick out what's going to work best for you. So if you navigate to the tool shed, what will pop up on your screen is all of these different searchable criteria. And this is basically the template that we use. So this is the shared language that we are moving through, with all the options that I'm going to talk to you about in just a minute would be in each of these drop-down boxes. And Matt's going to walk you through that when he goes through some examples and shows you how to navigate through it. So if we look at each of the sections that we tried to capture, we tried to think about who might be using it and how might they want to filter some of this information. We also looked at what was available in the literature, and some of these categories are aspirational. There may not be much literature in that area, but we hope that recognizing that there isn't anything specific to these areas, it will help to drive some potential resources or research in the area so that we can continue to say that these things can or are effective for these types of learners. So we divided out by education setting, didactic, simulation-based, which may still be within the didactic, but really focusing more on a simulation rather than maybe a classroom activity, and then within the clinic. You can do search by the learner, so whether or not there's been, and these are, again, are all based on what evidence is out there. So whether or not it has been researched with PTs, PTAs, both, or even in other health professions. Different educational levels. So there are tools that have been studied in fellowships and residencies, as well as within the entry level program, so that people can find something anywhere along the way. In areas of practice, this is probably one of the most aspirational areas. Most of the literature that's out there is general, either general practice or unspecified, but we hope to show that there might be specific tools in certain areas that would help you to focus in. There are some specific tools already within ortho, and we might see this grow as well. In the domain of assessment, right? So as Jackie talked about, there's a lot of aspects that are a part of our clinical reasoning, and it's not all just the cognitive. And sometimes we are assessing the cognitive, but sometimes we need that affective or psychomotor. And so figuring out which tool does a better job of that is really helpful. We looked at different types of assessments and whether or not the learner is going to be self-assessing. So do you want to have a tool to help you better assess your learner? Or do you want a tool that will help guide your learner, or that they can self-assess themselves? We used mostly the work from Edwards, and this is also, we hope to link in some of the work that was done by the consortia group as well in defining the different types of clinical reasoning. So that should be linked in the coming month or so to the different types of clinical reasoning, but defined out the different types and what you're trying to assess. How and it's administered. So some of these do have a cost associated with them, and that may be part of your decision making on whether or not that is something that you want to take on, how long it takes to do it as well. We looked at the literature on scoring and reliability and validity, which may or may not be available on every tool, but we tried to publish that with our summary documents, as well as these advantages and disadvantages. So we want to be clear that this is based on a consensus of opinion, based off of those who are working on the template, and then this executive committee that would go back and do editorial review, is to say what are the advantages and disadvantages of this tool. And we hope that that continues to grow, as well as citing what kind of evidence is out there. Is this just in single case studies, randomized control trials, all that, so you guys have so that you know what type of studies have already been done and maybe where the gaps are in the literature. We pulled out some examples of use so people know how it's already been used within the literature, ideas for adapting it. Again, this is based off of consensus, so maybe there's not literature available in specific settings or specific areas, but we feel that after having reviewed the tool, we think that it might be able to be used in other areas. And so we hope people will try that. We hope they will do research on that, and we can come back and later say whether or not it's effective for people. So this is basically what we did when we went through and created these summary documents, so that if you're going in and searching and trying to figure out which tool is the best for you, is there something within that tool that is going to be helpful in the type of learner you're working with. So we wanted to kind of give you an example. So at this point in the toolshed, we don't have, we kind of have talked about, we'd love to have the option where you can, compare cars online and see multiple cars and what are the pros and cons of each and what fits for me. So we don't quite have that as a click button at this point, but you can take, because we have this shared language, some of the different tools and be able to compare them. So I did that with the SHRT and the SACR to give you an example. So I highlighted what's bolded and underlined is where there are differences. So in the SACR, it has been researched within the clinical setting, whereas the SHRT has not. Who the learners were different. What educational levels has it been researched in was different. Not to say that it couldn't be used in other levels, and that's where you kind of go through those advantages and disadvantages, but this is the literature that we have right now. So you see there's different areas of practice, different domains of assessment. The type of assessment that you're doing, whether or not it is learner self-assessed, the type of clinical reasoning, a big difference here in the administration, in the cost for the SHRT versus the SACR, the amount of time that it takes. So this really helps you decide if this is something that's appropriate for use in your setting. And then going into the summary of the reliability and validity, as well as advantages and disadvantages. So that's what the work groups that are pulling together these summary documents that are in the toolshed have already gone through, looked at all the literature and summarized this so that it's easier not only for educators to access it, but then to know how to use it as quickly as possible and not have to go look at all the research that's out there. We also provide to you what is the current evidence, those examples of use, and then here's an example of how you might adapt each one. And these are suggestions from the executive board and from the those in the work group that have been doing these small groups to say, here are some additional ways you could use it. So I'm going to pass it off to Matt, who will actually show you the toolshed on the screen and how you might be able to look at it from a different lens depending on what your background is.
All right. Good evening, everybody. So my part is a little bit, I'm going to go off the PowerPoint and actually click around in the toolshed to give you an idea how you might use it in real life. We're going to use these three scenarios here. We'll look at it from a didactic educator perspective, who's a guy that just went over maybe into the simulation library and found a great simulation to facilitate diagnostic reasoning for low back pain. But as a good educator, they need to find a way to assess the outcomes of the learner. So we'll look for something that maybe can help with that. Then we'll do another scenario where an educator in a residency program is looking for an evidence-based way to assess their residents' clinical reasoning abilities, or maybe to compare what's in the literature to what they're already using. And then the last one, researchers looking for gaps in the literature in assessing clinical reasoning in an acute care situation. You don't have to look too far to find a gap. All right, so bear with me while I get to the library or the toolshed. All right, so here's the toolshed. So to find the toolshed, you can use the link that Jackie shared with you, but also it is in the resources of ACAP's website. And the first scenario I'm going to take you through is the didactic educator. So we're going to go to our education. Well, before I do that, I do want to, as we want to be fully transparent, if I don't put anything in the search engine, and I just search, that'll give me, oops, I need to clear my search. All right, make sure everything's clear. And search without anything in here. This shows you the tools that we have so far. So as it stands right now, I would not limit your search too much, and you can look through these. Now, we do have several in the pipeline, so this will be growing hopefully pretty soon, and we have aspirations for it to grow quite a bit bigger to where you're going to need some of these search strategies. But in all honesty, at the moment, you probably don't need these search strategies. You can just click on the tools that are there. But let's imagine that we are looking in the simulation-based education setting, and we're trying to facilitate diagnostic reasoning. So I'm going to put that to diagnostic, and let's just see what we get. So we get 3 tools. We got the CRAT, the WAC2, and the script. And so we can look through these and decide if that's what we're looking for. We just open the tool and look at the full description. And then if we did that with these 3, we would realize that none of these really are self-assessments. But if I go back, I'm not going to try another search. I'm just going to go back and modify this. We're going to leave diagnostic reasoning, but I'm going to broaden it out to not set an educational setting. And we'll search again. And now the diagnostic thinking inventory comes up. The reason that it didn't come up with simulation-based education is because it hasn't been described in the literature as being used to facilitate simulation-based learning. However, it could easily, it's not a stretch to think that you could use the DTI to debrief a simulation. So if the message here is to don't be too restrictive with your search. You might find something that you would like that you otherwise wouldn't see if you're too limiting. Let's try another search as a residency faculty. So we're going to start with our educational level as post-professional. And we're not going to be directive on anything else, just that. And we'll just see what's there. So we see, okay, we've got 2 that have been described. There may be other tools that'd be useful, but these are the only 2 that have been described in the literature so far for post-professional. And like Anita was saying, I might want to compare the 2. Right now, you can't put them side by side, but you can open it up and get a quick description. It's a 38 item multiple choice. And maybe I'm already thinking, I didn't really want a multiple choice exam. I wanted something more to facilitate mentorship. And if I scroll down, oh, it's got a cost. I don't have a budget for this. I don't know if this one's going to work. Let me go back and see what that other tool looked like. And maybe looking through the details of the script is maybe it fits my need better by looking at the description and the administration. Okay, it's long. I don't know if I have that much time, but it's free. And this can just help facilitate a quick appraisal of if this is something you want to look more into. If it is something you want to look more into, you can click on the primary reference, and it'll take you to the place where that primary article is. Oftentimes, if you go to the supplementary data and look for supplementary material, you can actually find the tool. And in this case, you can find the script readily available right there by the authors. That's not always an option. So you may get back. Let's just do this. So if it's not an option, you may have to look up Baker and reach out to the primary authors themselves. In my experience, authors love sharing their stuff. So if you reach out to them, you could probably figure out a way to get the tool if you can't find it easily. We aren't able to put the tool directly on the Toolshed just because of copyright rules. So but oftentimes it's not too hard to get to it. Let's do one more search. This one should be pretty open. So if you're a researcher in the scholarship of teaching and learning, there's a lot to research. So let's just imagine that maybe your practice area is acute care, and we're interested in clinical reasoning and acute care. Let's see what's there. And so far, there's nothing. So you got plenty of room to build things. Actually, I think maybe you are a researcher, and I think I saw something not too long ago about a script concordance test to help facilitate choice of assistive devices in acute care. If you're that researcher and you see, hey, why isn't my tool in here? Then reach out and get it there, right? So another cool thing this is the part that I'm really excited. see if I can navigate to the right spot. Nope, not that. Uh, if y'all haven't visited the ACAP website in a while, it's changed a lot. And this is the part that I'm kind of excited is there's actually a community for the clinical reasoning toolshed. And so we can start discussions. So if you're that researcher that's got a cool tool for acute care and you want to make it known, you can start a discussion and have a back and forth. If you're that educator that took the diagnostic thinking inventory and used it after a simulation, you can talk about it here. You can start a conversation and we can start to have an online conversation about how we're using the tool shed and the tools in it to better facilitate and assess clinical reasoning in our environment and kind of spread the word so that we can all kind of adopt each other's best practices and all do great things together rather than in our kind of isolated silos. Let me get back to this. I'm going to turn it back into presentation mode.
I would also add that as a researcher, looking at that ideas for adapting or use in other contexts, which were just suggestions by the editors of this, would be a great place to start to say, here's some areas where we think it could be used. And if that's an area that you would like to research further, you certainly could do that.
Thank you. Yeah, I did want to show that. Let me get to the, I'll show it. If we just take any of them, we'll just take the DDI. This part down here, the appraisal, is a little bit of an editorial from the task force, and you can add to that in the conversations. But this will get you started of where you might be able to adapt it and change it. Am I missing anything else? Kevin, Jackie, Nita?
We're good.
All right, let's go back.
All right, well, thank you, Matt. So now that we've kind of looked at the tool shed, what's on the horizon? Well, on the screen here in green, you can see the tools we selected. We've selected tools we thought were widely used and have they're now available in the tool shed. The 3 in yellow are currently being reviewed by work groups, and we're hoping to get those up soon. The items in red are what's next on the list. And so we're looking for people to join us in work groups, and hopefully by the end of the year, those will also be available on the tool shed. Our future aspirations. We've talked a little bit about what else can we do to make this more usable. A comparison tool side by side is one of our ideas. Other ways to update the information to make it more searchable and more useful for different types of users, depending on your setting. We talked about the new onset of the discussion item, kind of extending the metaphor of a tool shed. Perhaps we need to next build a patio or some other way for people to sit down and talk about clinical reasoning, come up with ideas, share best practices of how they're using these tools in their particular educational setting, and just continue sharing amongst this community of how clinical reasoning is such an important centerpiece of what we're doing and the best ways to do that. And then finally, for those with interest in research, where are the gaps? Where do we need specific clinical reasoning tools, and how to maybe expand current tools to better cover areas that are needed, especially in residencies and some other types of clinical settings. So those are some of our future aspirations. And if you have an interest in this area, we invite you to join us and help us develop this particular resource. There's our QR code. Finally, we like to tell you about another group of people who are interested in clinical reasoning. This is a group that had an article that was published in the Physical Therapy and Rehabilitation Journal, and they wanted to share that information. And as it turns out, a Thursday at 7 o'clock Eastern Time was a perfect time for them to do that. And so they're currently on another webinar with the Academy doing that. And so if you have some interest, here's a link to their webinar if you want to pull that up and review what they've covered about that. But what's important is that the compendium that we are part of put together a group of people of interest, and this was a group of people that also continue to look at clinical reasoning and what's the best tools to use in physical therapy education. So we just want to make sure people are aware of that and spread the word about other resources that are available to look and consider clinical reasoning. This webinar has been recorded. If you have somebody you think might be interested, we invite you to share this link with them. It will be available on the ACAP website, and so they can see what's going on, get a sense of how the tool shed has been put together, and hopefully they can share in the process as well. With that, I think we'll bring our webinar to a close unless you have questions. We'd like to kind of hang around a little bit in some breakout rooms and make ourselves available to you, see what your ideas are, see if you have any additional questions about using the tool shed, and just your overall interest in using clinical reasoning tools in physical therapy education.
Do we want to kick people to breakout rooms to have small group discussions? We still doing?
Yes, so I can go ahead and start the breakout rooms for those that are still with us in the meeting and have any questions for any of our presenters today. Going to start those now.
Great. Okay.
Hi, Michael.
Hello, can you hear me?
I can.